really a pleasure to be back to the ninth media conference. Thanks for the kind introduction. And I would like to thank also Dr. Mamdouh Suwailem and Dr. Sherif for their kind invitation. So parenteral nutrition for neonates, an overview. So by the end of this session, we shall be able to list the parenteral nutrition indications in neonates, to outline the importance of early optimal parenteral nutrition, to review the neonatal parenteral nutrition's contents, the fluid requirements, and PN as part of a total fluid intake in babies, the energy requirements and non-protein energy, the macronutrients, the electrolytes, the minerals, and the micronutrients. So as a quick introduction, in late 60s, Dr. Diudrik and his colleagues were working on or experimenting on supplementing nutrition through the parenteral route. They used central catheters, central IV catheters to introduce nutrients. They started with animal studies, and then they were successful in about 8 adult patients. By that time, baby Colleen in one of the hospitals in the United States was born with a congenital anomaly that prevented the baby from feeding enterally. The baby was not growing, was failing to thrive, and was sentenced to death unless the intervention by Dr. Diudrik and his colleagues, who tried the same, giving nutrients through the central line, and they were actually successful in saving that baby and bringing her weight up from 3.5 pounds only to 6.5 pounds in a stream of 6 weeks. So this leads us to the fact that in our today developed medicine, parenteral nutrition is a core element of the care of these preterm babies, and that central line, despite its hazards with infection, as we heard earlier, is a lifeline for these babies. So we are talking usually about starting nutrition early in preterm infants, but why early? We know that they have low tissue energy stores. Their glycogen, if any, is only produced during the 3rd trimester, so they have missed that phase in the pregnancy. Therefore, they will consume that glycogen in a very short time after birth. They have obligatory tissue catabolism, where we know now that they break their own body's protein at a rate of 0.5 gram per kg per day, and some experts say even more than that. They have essential fatty acid deficiency. They present early in life with disturbances in circulating electrolytes, especially a problem of hypernatremia, probably due to dehydration. They show fluctuation in their glucose readings. They show delayed tolerance to full enteral nutrition due to the prematurity of the intestine, and that compels the need for parenteral nutrition. And they most of the time show incomplete catch-up growth and development when you compare them to the peer full-term neonates. Now, despite it is a lecture about parenteral nutrition, I would like to emphasize the importance of enteral nutrition, and namely early trials of enteral nutrition. So it is encouraged as early as possible, maybe earlier in the form of small amounts, what we call trophic enteral feeds. And according to the risk of your patient, you want to advance by about 10 milliliters per kg per day at least, and according to the risk stratification, maybe even more than that. But why is it that I'm emphasizing the importance of enteral feeds? Because it is the physiologic route. It has shown positive outcomes for the GI mucosal integrity, the absorptive ability, and improvement to the immune function. Of course, the risk of infection, as mentioned, is high with parenteral nutrition, especially when combined with a prolonged NPO status in these babies. So the central line brings the risk, plus the NPO status and the atrophy to the enterocytes promotes translocation of bacteria and systemic infections. We know that enteral feeds are positive to the health of the liver. Even those babies who's been on prolonged parenteral nutrition, as soon as you start some enteral feeds, you notice improvement in their readings of direct bilirubin and less liver disease. And of course, prolonged NPO has shown on these babies to show some behavioral changes like oral aversion. They don't like to be fed by mouth. So now that we know the importance of early enteral feeds as well, let's go back to parenteral nutrition and see then what are the indications of parenteral nutrition in our preterm babies. So prematurity, of course, is the most compelling factor. Most of the units stick to less than 30 weeks gestation due to the gut immaturity and weight less than 1,500 grams. And recently, some units are adopting less to 1.25 kilograms. So less chance for babies to get into parenteral nutrition unnecessarily. And then there are other indications, namely pathology of the gastrointestinal system, precluding it from becoming the useful route of enteral feeding, at least temporarily. Some of these are surgical cases like neck necrotizing enterocolitis, in which sometimes requires some intestinal resection. If massive, might result into short bowel syndrome, which compels us to very prolonged periods of parenteral nutrition, and then some other surgical, temporary or long-term, like diaphragmatic hernia and others. So there are other indications also when the babies are very sick and hemodynamically unstable, undergoing shock, for example, especially with very high doses of vasopressors. The ischemia to the gut cannot be excluded, and sometimes a decision is taken for individual patient to hold enteral feeds at least temporarily until we think that the perfusion to the intestine has been improved. And then, of course, in different other conditions, surgical or very sick babies, according to the clinical decision. But when to start parenteral nutrition when it's indicated? Most of the literature support early introduction, and even some experts say within the very first hour of life. If you think about it, this baby, when a fetus in uterus, was getting continuous supply of nutrients in the uterus. So you want to try and replicate that as soon as possible. So recommended early for and including lipid from the first day of life, as well as vitamins and trace elements from the first day of life. So the literature speaks to us about short and long-term benefits. Moises and colleagues in a systematic review in 2013 spoke about the short-term benefits. They spoke about getting quickly, regaining the birth weight and better weight at time of discharge with no evidence of increase in morbidity or mortality. The SCAMP trial published in the UK in 2014 spoke about the long-term, talking about decreased postnatal growth failure and namely better head circumference readings, which tells us about a better neurodevelopmental outcomes. And recently, the European Society for Pediatrics Gastroenterology, Hepatology and Nutrition guidelines published in December 2018, the most up-to-date from this organization, recommending to start parenteral nutrition as soon as possible after birth so as to avoid metabolic shock caused by interruption of continuous feeding that occurred in utero. So now that we know that we need to start as early as possible, what are the components? Of course, fluid as a vehicle for the different macro and micronutrients. Energy is very important, and we'll give the amounts. Macronutrients, we call them macro because they are needed in relatively large amounts and because they are the energy providers. Those are your proteins, your carbohydrates and lipids. Electrolytes, sodium, potassium, minerals, calcium, phosphorus, and magnesium, and the micronutrients. Micro because needed in small amounts, but very essential and important as coenzymes for many of the biochemical processes in the body. Those are our trace elements and vitamins. So fluid and energy, how much? For the full term, in the first day of life, usually about 40 milliliters per kg per day. Often we start them on 60 milliliters per kg per day. We increase by about 10 to 20 to reach a reasonable volume to provide good nutrients and to take the solute load in the circulation, so about 120 to 150 milliliters per kg per day. But the preterm infants usually need more. So in the first day of life, we start them at least 80. Sometimes we start them at 100 milliliter per kg per day, and we monitor their blood gases and we look at readings of sodium. We monitor their fluid balance almost every 6 hours within the first 24 to 48 hours, because this is the time when they seem to sometimes need more fluids to overcome problems of dehydration and hypernatremia. But usually the usual increments, if everything is okay, are about 10 to 20 milliliters per kg per day. And we mostly stop at 150, 160 milliliters per kg per day, where they seem to get reasonable amounts of calories, but some of them might need a little bit less or a little bit more. And we need to remember that parenteral nutrition is part of the total fluid intake, and that if there are other fluids that are running either to keep the patency of arterial lines or to deliver continuous infusion inotropes or sedatives, we have to deduct those volumes, and what's left will be your parenteral nutrition volume. Otherwise, you might be infusing diluted amounts of parenteral nutrition that are deducted for different fluid purposes. What about the energy requirements? If we look at the basal energy expenditure, it's about 40 to 60 calories required just to keep the vital organs and to keep living and breathing. And then energy for growth for those babies, about 45 all the way to 67 calories to put on about 15 grams of weight daily. Unlike adults, here we're not thinking a lot of energy for activities and movement. So the ESPGHAN in 2018 guidelines for the preterm infants, they recommend 90 to 120 calories per kg per day. In the recovery phase, that's usually beyond the first 24 to 48 hours. In the first day, which they called the acute phase, they are okay to stick to up to 55 calories per kg per day, only because you cannot reach higher than that, as you are limited by how much total fluid intake in the first day of life specifically. The factors that influence the energy requirements in these babies are mostly factors that we try to control while caring for those babies in incubators with temperatures that are controlled and humidity that is controlled. So prematurity leads to heat loss through the premature skin, and that's why they are in controlled incubators. Low birth weight, they have very high active organs that are premature and trying to catch up, so the energy for the whole body is very high. When they are under physiologic stress, they seem to sometimes need more calories, more energy. If you think about respiratory failure and how they need to recruit the respiratory muscles to keep breathing, they will need more energy. The feeding method, enteral feeding, requires energy for digestion and absorption, while with parenteral, that is negligible. And the ambient factors, we spoke about them. So the energy source, it's very important to emphasize on the non-protein sources of energy, namely the lipids and the dextrose. And the experts recommend almost 50-50 of non-protein energy to come from dextrose and lipid, but many times we end up giving a bit more from dextrose than we do from lipids. And the experts also emphasize on an important ratio: how many non-protein calories you give for each 1 gram of protein. And that ratio seems to be between 20 to 25 calories per 1 gram at least. Some experts speak about a bit higher than that. And this is important because you want to have the protein to go into tissue synthesis and growth for these babies, and not to be turned into calories because you are giving less non-protein calories. So next we will speak about those macronutrients that bring in the protein and the calories. Speaking about the protein, it's important to start early and to start optimal amounts as you start parenteral nutrition, so along with dextrose and lipids. The evidence has shown that this prevented significant protein loss and catabolism, showed minimal catabolism, as I mentioned, and resulted into positive nitrogen balance as early as the first day of life. So again, if we go back to ESPGHAN's recommendations, as well as the American Society for Parenteral and Enteral nutrition recommendations of 2019, we see that you can start your first day to add amino acids in about 1.5 at least, all the way to 3 grams per kilogram in the very first day itself. And then you can advance to a maximum of 3.5 to 4 grams per kg per day. The 3.5 is the upper limit with Ispagan, and up to 4 grams is the upper limit with Aspen. For the term infants, 2 to 3 grams per kg in the first day seem to be reasonable, and then you stick to 3 grams as your upper limit per kg per day for the term infant. Now let's speak about the second macronutrient, the carbohydrates in parenteral nutrition, and in parenteral nutrition, they come as dextrose. And it's important here to speak about the rate of dextrose infusion. So we no more refer to the dextrose in parenteral nutrition in percentage or even in grams per kg. The best is to speak glucose infusion or dextrose infusion rate in milligrams per kg per minute. And because the literature will give you the recommendations based on these numbers, and you can then evaluate whether you are underfeeding or overdoing it with the dextrose infusion. So the first day for the preterm baby, 4 to 8 milligrams per kg per minute, you increase gradually by 2 to 3 to reach a target of 8 to 10 milligram per kg per minute. So in this range, you are being nutritional, you are giving nutritional amount of dextrose. The maximum is 12 milligrams per kg per minute if you need to overcome hypoglycemia or to give more calories, but more than that will cause problems, and we'll speak about it. For the term baby, maybe a bit less in the first day of life, and we target 5 to 8 with a maximum of 12, 13, but sometimes we have to give more to some of the term babies as they sometimes struggle with hypoglycemia due to being born to mothers with gestational diabetes. So really in hypoglycemia, and I'm asked this question a lot, we infuse up to 14, 16 milligrams per kg per minute. Theoretically, there shouldn't be a ceiling because of the consequences of hypoglycemia on the brain. So where did we get these rates from? Basically, these are physiologic rates. If the baby is left alone that preterm, not given any source of carbohydrates, they will produce endogenous carbohydrates as much as they can to support the brain, and they will start 4 to 6, 4 to 8 milligram per minute. So that's your starting point. Where did we get the maximum from? It's the maximum oxidative capacity of the liver, over which, so if you infuse more, 13, 14 unnecessarily milligrams per kg per minute, the liver will just turn it into fat and store it. Why dextrose? As mentioned, it's the main or the chief energy source for the neonatal brain, a metabolically active organ beside the other organs. We noticed that the serum glucose will drop within the first 1 to 3 hours, but then they will pick up, and sometimes they go into gluconeogenesis for some time and produce hyperglycemia, but we know that they have limited stores of glycogen, and thus it's important to support them with a balanced nutrition containing dextrose as part of it. Now, the consequences of excessive dextrose intake, hyperglycemia that causes osmotic diuresis and dehydration and sets the stage for sepsis, so it's not recommended. Increased carbon dioxide production, which might sometimes interfere with ventilation. Lipogenesis, as I mentioned, higher rates of infusion will compel the liver to turn them into fat and store them in adipose tissues. But when the excessive infusion continues, the liver is not able to move these fat molecules outside and will be stored on the liver itself, causing liver steatosis and inflammation to the liver. Now to the third macronutrient, the lipids. They are tolerated from the very first day of life. The recommendations is to start already 3 grams per kg per day in the first day, immediately after birth, and the maximum is documented to be 4 grams per kg per day for the preterm infant, and preferably to include some lipids that contain omega-3 fatty acids, as they are thought to have an anti-inflammatory effect on the liver. Why the lipids? They are source of very high non-protein energy in small volume. So 1 gram of lipid emulsion, 20% is only 5 milliliters, does not add a lot to the total fluid, even in a fluid restricted patient, and will give you 10 calories. So will improve your calories intake on those babies significantly, and therefore improve the net nitrogen balance. They contribute low osmolarity to the TPN, so they are not irritant to the veins, and they provide the essential fatty acids that are needed for the neurodevelopment and for the integrity of the skin, amongst other functions. Now to the electrolytes and minerals. We usually keep electrolytes, sodium and potassium, in maintenance amounts. And sometimes we have to correct in the parenteral nutrition if there is strict fluid restriction. So sometimes, yes, we might give a bit more than the maintenance if needed. Limited intake of sodium in the first day of life. Many units now revert to giving only a little bit of sodium glycerophosphate that will serve both phosphorus and a bit of sodium in the first day of life. And that's because they usually show hypernatremia in the first few 24 to 48 hours of life. And they will be getting sodium from many sources for flushes and for patency of lines. Potassium, usually classically we say none on the first day of life, but then 2 to 4 millimole per kg per day. But recently, ESPGHAN and in their most up-to-date guidelines, they ask us to review our statement about no potassium from the first day of life, and also the phosphorus. And that's because these babies are prone to refeeding-like syndrome, because with the high intake of amino acids and dextrose, there will be some intracellular shift of potassium and phosphorus, which put them at the risk of refeeding syndrome with consequences on the cardiovascular system. So if you establish the renal function, baby passed urine, it seems that the renal function is normal. We don't have evidence of accumulation of potassium and phosphorus. Why not maybe give a little bit potassium from the first day of life as well, maybe in the form of potassium acetate, maybe 1 millimole per kg, to help you also combat that metabolic acidosis that we see early in life with these babies. The minerals are calcium, phosphorus, magnesium, important to include from the very first day of life. During the third trimester of pregnancy, those babies will get high amounts of those minerals in utero, and when they are born prematurely, they have missed that, and therefore they are prone to osteopenia of prematurity. Some experts speak about the ratio, the molar ratio between calcium and phosphorus, and they recommend calcium to phosphorus to be 1.3 to 1 and even 1.7 to 1, which is in the practice difficult to attain. If you think about it, you always are struggling with higher readings of ionized calcium, and we're worried about nephrocalcinosis and other problems. But if you get the chance, sticking to this ratio might help the accretion in the bone and avoid osteopenia of prematurity. I'm about to conclude. These are my last two slides about the micronutrients. We have multi-trace element solutions that contain zinc, copper, manganese, selenium, and they all known to have physiologic important roles, specifically zinc for the integrity of the GI system and the skin, and maybe extra of it is needed in short bowel syndrome infants. They, most of them act as coenzymes, as I mentioned, in biochemical processes in the body. Chromium comes as a contaminant, but has a physiologic role, so we're happy with it. But aluminum sometimes comes as a contaminant with parenteral nutrition that is toxic and doesn't have physiologic role, so we try to limit it. The vitamins are the fat-soluble vitamins, A, D, E, and K. They all should be included, as well as the water-soluble vitamins, vitamin C, and the B vitamins. And as the trace elements, they are also coenzymes in many of the biochemical reactions important for the health of these babies. So here I conclude. Thank you so much. And